So it's 3, 2, 1. Over to you, Lokesh sir.
Good evening, everyone. Myself, Dr. Lokesh Sai from the medical team Macloids. I welcome you one and all. As we all know, India possesses huge diabetic burden. And did you know, 1 out of 7 in all world diabetics are Indians, which in terms of prevalence, India stands second place, which is one of major risk factor for the cardiovascular and as well as renal complications. Understanding therapy and its molecules also very important. So with this, I would like to invite renowned consultant diabetologist and endocrinologist from Jammu and Kashmir, Dr. Raj Kumar Sharma, as our esteemed speaker for the day. Sir, thank you. Over to you, sir. Hello.
Hello. Hello.
Hello, sir. You are audible, sir.
Should I start?
Hello.
Yes,
Sir, you can start.
Yes.
Yes, sir.
Thank you. Thank you. I am very thankful for you to have given me a chance to talk on a CME, which is on a very important subject.
Sir, it's our pleasure to have you with us, sir.
In diabetes management, with or without CV risk, dapagliflozin takeaway points. We all know that India, being the capital of diabetes, has more than 7 crore people suffering from diabetes itself and many more suffering who are undiagnosed. And cardiovascular disease is a coexisting with the diabetes, and the risk of cardiovascular disease in diabetes is very high. So now we have one drug in our armamentarium which would have effect on the comorbidity of CVD with diabetes and can improve the outcome. So we'll be talking about dapagliflozin takeaway points in the next slides. We all know that in the world there has been increase in the number of diabetics. In 2019, there were about 463 million people, and these are going to increase by 700 million by 2045. That is approximately 50% increase in the next few years. While if you talk of Southeast Asia, the number is going to go from 88 million to 1.153 million. That is, the increase is 74. And India comes out to be one of the major constituent of this rise in the diabetic population. So if you see in the world that today, every 7 seconds, there is one death from diabetic or its complications. Diabetes and elevated blood sugar levels are associated with an approximate doubling of cardiovascular risk disease. We know that association and impact of diabetes on cardiovascular disease. The prevalence of cardiovascular disease, any cardiovascular disease, is increased by 32%. Coronary artery, 21%. MI or myocardial infarction by 10%, and stroke by 7.6%. So you can imagine how much load we are going to get from these patients of cardiovascular morbidity. So in diabetics, there is increase of risk by 160%, ischemic heart by 127%, hemorrhagic stroke by 56%, and cardiovascular death by 132%. So you can imagine how much increase in the problem comes once you have underlying diabetes. The cardiovascular disease behaves very radically. So what are the years life lost? 5.8 years for the men above the age of 50, and 6.4 years for the women above the age of 50. So you can imagine how you are cutting short the lifespan of sorry, so many people with the onset of diabetes and its comorbidity of cardiovascular disease. So see, there is a diabetes interdependence relations. So these are coexisting things. What happens in the diabetes? There is hyperglycemia, there is insulin resistance, hyperlipidemia, obesity, hypertension, inflammation, oxidative stress. This leads on to what? It leads on to the LV remodeling, loss of contractility, and myocardial stiffening. Subclinical left ventricular dysfunction, heart failure, and death. Similarly, if you have diabetes and smoking, there is atherosclerosis, LV hypertrophy, coronary artery disease, myocardial infarction, and finally the death. So, sorry. So these things are going to contribute to a greater extent. Once you have myocardial dysfunction because of obesity, high BP, sedentary lifestyle, smoking, dyslipidemia, and hyperglycemia. And over review of the assumed pathophysiological mechanisms of diabetic myocardial dysfunctions. So whenever you have the myocardial dysfunction because of diabetes, the mortality as well as the morbidity is going to increase. So we know that diabetes is the ominous octat, and there are current available therapies for that. So first thing is there is decrease in creatine effect, and DPP-4 inhibitors act on that. There is a decreased glucose uptake, thiazolidines act, neurotransmitter dysfunction. We have increased hepatic glucose production, metformin acts there. We have DPP-4 inhibitors acting on increased glucagon secretions. Insulin and sulfonylurea act on impaired insulin secretions. So we have 8 mechanisms which are to be taken care of, and there is increased glucose reabsorption, and specific drugs as GLT2 inhibitors act on that. This is a newer drug, not newer, but of the newer variety of drug which is being used in the treatment of diabetes with coexisting comorbidities. Where are the OADs and altitudes is placed as per the guidelines. So if you see the position of SGLT2 in international guidelines, the proven class since 2018. 2018 ADA-ESD consensus report says the first line of course, is the lifestyle modification and use of metformin. And once the contraindication is not there for the metformin, then you have to use it. And if HbA1c target is not achieved, or once you have the ACVD predominating, the drug of choice is GLP-1 receptor agonist or the SGLT2. Similarly, if you have heart failure, CKD predominance, preferably SGLT2 inhibitors, if not possible, GLP-1 receptor agonists. So these are the drugs which are now available in our armamentarium in the management of these two conditions. 2019 HCC AHA practical guidelines shows consider metformin as the first line drug therapy, and if A1C is not below 7, and in patients with other cardiovascular disease risk factor primary prevention, consideration can be for SGLT2 and SGLP1 receptor agonist. So these are very clear-cut guidelines where which SGLT2 has its own role to play. However, 2019 ESC guidelines says Metformin not necessarily considered as first line therapy. So metformin, which we were always using, this guidelines say that you may not use the metformin in a condition where you have AICVD as well as high risk of the cardiovascular disease risk. You can start straightway with the SGLT2 or SGLP, GLP-1 receptor agonist. So this is a very, very prominent drug. And with the passage of time, with the more and more people adapting to these guidelines and the availability and cheaper availability of the dapagliflozin nowadays, this drug is going to take over all the other drugs and maybe the first line of action. Again, the same 2021-2022 guidelines of the ADA. This again shows that ASCVD indicator risk, high risk GLP or SGLT2. For patient on GLP-1, consider recruiting as GLT2 when proven CVD benefit and vice versa. Similarly, heart failure at GLT2, CKD with or without albuminuria, you have to use the again SGLT2 to prevent the further damage. Well, of course, the other guidelines we all have gone through. I'm focusing more on the SGLT2 here. So among individuals with type 2 diabetes who have established HCVD or indicators of high CV risk, established CKD or heart failure, SGLT2 inhibitors with demonstrate CVD benefit is recommended as a part of glucose lowering regime. So this becomes a first line of drug in those patients with underlying cardiovascular disease. So patient with clinical preference and priorities considering the SGLT2 inhibitors with demonstrate CVD. So where we have MACE prevention 3+, heart failure prevention 3+, weight loss 1+, weight loss 1%, 1+, renal disease progression 3+, and similarly you have simultaneously even the blood pressure reduction to mild few degrees, and the mode of administration is also oral, where this may not be an cause of the drug, and you may have to use an alternative class of drugs where it doesn't fit, especially severely reduced kidney functions when GFR falls below 15, where the GFR is low, so these drugs will not be effective. Surgery of the history of prior surgery or amputation, severe peripheral artery disease, or active foot ulcer. History of recurrent gentle candidiasis, history of recurrent diabetic ketoacidosis, history of fracture caution, especially with the kind of glyphosate. The patient is considering for the pregnancy. The patient is breastfeeding. So these are the contraindications to the use of SGLT2. So in a patient with type 2 diabetes and ASCVD, at the time of diagnosis of clinical ASCVD, DKD, or diabetes kidney disease, or as heart failure in a patient with type 2 diabetes, or a drug regime that doesn't include a GLT2 inhibitor with CB benefit. At the time of diagnosis of T2 diabetes, patient with clinical ASCVD, DKD, or having heart failure, at a hospital discharge with patients outpatient after admission for ASCVD or heart failure, in a patient with type 2 diabetes and diabetic kidney disease, in patient determined to be high risk of ASCVD. So in these conditions, you have to use the SGLT2 inhibitor. So SGLT2 inhibitor is the star in the treatment of diabetes, especially at the time of launch. What were we using? Type 2 diabetes, particularly young to middle age group with obesity and metabolic syndrome. Those patients who have simultaneously the metabolic syndrome or have a younger age group, to prevent the onset of diabetes, the complication of diabetes, especially the cardiovascular, you have to use SGLT2 as a priority. And we all know that we should try to prevent the mortality and morbidity occurring later on. So by giving a SGLT2 initially, you can prevent the onset of ASCVD. So why not start it earlier before it occurs? So not only that, so patients even without ASCVD, you should give in a younger age group the SGLT2 inhibitors rather than waiting for them to develop ASCVD. So current, in addition above the patient with type 2, those who have CVD, those who have heart failure, those with the diabetic kidney disease with the GFR more than 30, those with type 1 diabetes, those with heart failure without diabetes, those with heart failure with preserved ejection fraction, those with chronic kidney disease without diabetes, those with pre-diabetes for prevention of type 2 diabetes. So you have a multiple role of SGLT2 in the management of diabetes or the coexisting conditions. So SGLT2 role in diabetic control, especially the glycemic control and beyond. Kidney is a therapeutic target organ missing in the which we had talked of this ominous octet, and then increased glucose resorption is taken care by SGLT2 once it is used. The need of OAD class with CV safety and survival benefit, especially the cardiovascular and then control of blood sugar, then we have SGLT2. The OAD class recommended by latest guidelines, whether it is American EASD or American American College of Cardiology. So all these guidelines clearly mention SGLT2, especially with the cardiovascular disease involvement or the kidney involvement. What are the how it is acting as SGLT2 inhibitor? We all know that it is in the acting at the PCT and it decreases the absorption of sodium and glucose. Similarly, increases the uric acid secretions. So ultimately leads on to the glucosuria and natriuresis. The clinical findings are decrease in the plasma glucose, decrease in the body weight, blood pressure is decreased, plasma uric acid is decreased, as well as glomerular hyperfiltration is decreased. So all the benefits we are going to drive out of the SGLT2 inhibitors on the kidney. So SGLT2 as a class effect has effect on the cardiac status. It has effect on the renal. It has effect on the pancreas. It has effect on the weight. It has effect on the parameters. It has effect on the blood pressure. So on the heart, cardiac and pre and after load is decreased. Decrease in the myocardial stretch or contractibility. Decrease in the ejection fraction. Increase in the FFA oxidation, which is the energy source in the heart. Increase in the glucose utilization. Decrease in the epicardial fats and inflammation. In kidney, glycosuria, negative caloric balance, natriuresis, diuresis, decreased glomerular pressure, decreased proteinuria, decreased atherosclerosis, which is as well as the uric acid. On the pancreas, decreased glucotoxicity, increased insulin production, increases the glucagon, especially the ketones, can be sometimes increased. So this is the only negative effect of SGLT2. So if you combine with the other drugs which have effect on the glucagon, especially the DPP4 inhibitors, you are going to get much benefit. The weight is reduced, insulin resistance is reduced, glucotoxicity is reduced, visceral fats are reduced, epicardial fats is reduced, and simultaneously the systemic inflammation is reduced. And the parameters, HbA1c is reduced, HDL is to reduce to some extent, triglycerides are reduced, inflammatory markers are reduced, ketones are somewhat increased, uric acid decreased, magnesium is increased. The blood pressure, because of increase in the laxity, decreased plasma volume, decrease in the volume load, and the hemocrits are increased. So you have all the benefits derived out of the SGLT2 inhibitors. Again, it products what we have already talked. It produces cardio as well as nephroproductions. Cardio productions, it does decrease the cardiac afterload and preload, increases the myocardial oxygen supply, increases the cardiac systolic as well as the diastolic functions, decreases the MACE, decreases the risk of heart failure. In the nephro, it decreases the intragranular pressure, decreases the blood pressure, decreases the progression of to the CKD. So the epagliflozin for the glycemic control, we have a lot of studies, 250 clinical studies. Initial therapy as well as on the metformin combination, DPP4 combination, sitagliptin combination, thiazolidine combination, and the combination with sulfonylureas. As an add-on to the insulin, in combination with GLP-1 receptor agonist exenatide, head-to-head, we have trials with the sulfonylureas. Dapagliflozin in CVD, more than 35 trials. Landmark trials are declared to be determined. Dapa HV, CVD, renal chronotic. Dapagliflozin, CKD, 12 trials. Dapa, CKD, and Delight trials. So we have multiple trials which have shown the benefit of SGLT2 in these conditions. So ultimately, we are not only controlling the glycemic control, it is beyond the control of diabetes, what we are doing with the help of SGLT2 inhibitors. So what we are doing, and its place in the therapy, it has effect on the fat, it increases the lipolysis, decreased sensitivity of the insulin which is there in the diabetes is improved. In the muscles, it increases the peripheral insulin sensitivity, improves the uptake with the muscles. In the liver, it decreases the hepatic glucose production. In GI tracts, increased gastric emptying and carbohydrate absorption is decreased. So increased GLP type of excretion with the is going to be there. In the brain, neurotransmitter dysfunction is affecting the metabolism being taken care of. In kidney, of course, the decreased glucose deabsorption, and in pancreas, the improving the beta cell function via reduced glucose toxicity, where dapa as well as the metformin are going to have effect. So these are the ways dapa will have effect along with the metformin. So these are the 24 hours HbA1c, 24 weeks trial with the HbA1c. So here you see dapagliflozin is in the 5 milligram 1.19. Dapa given in the dosage of 10 milligram 1.45%. Dapa with extended metformin 1.2% with the 10 milligram. Sitagliptin with metformin 0.9. Dapa with sita 0.45. And similarly with the sulfonylureas 0.8. Placebo glimepiride again 0.1. With zolidines 1%. Placebo with bio 0.40. Dapa with insulin 0.9. So ultimately, add on with the DAPA leads on to 1% increase in the decrease in the HbA1c from the point where we start. So change in the body weight, if you see, there are different trials which shows that there is a decrease of the placebo effect is 0. With DAPA, there is around 3.7 kg. Again, DAPA with PIA, there is 1.5. DAPA with glimepiride, 5 kgs. DAPA with sita and metformin, 0.4. DAPA with metformin, 0.5. DAPA alone, 0.27. DAPA alone, 5 milligram, 2.61. So ultimately, you have around 5 kg once you are combining it with the other drugs, or alone, it leads on to 2 to 3 kg weight loss. So similarly, it also leads on to the decrease in the seating systolic blood pressure. With DAPA with metformin 0.4, DAPA with metformin again 0.5, 5 millimeters fall, and DAPA with metformin again 5 millimeters. So around 3 to 5 millimeter fall is observed. 3 millimeter alone, and with combination, you have around 5 millimeter fall in the systolic blood pressure. So the efficacy and safety of dapa in combination with oral hypoglycemic agents, patients with type 2 diabetes, the systematic review and meta-analysis. It shows the objective of these meta-analysis was DAPA, a representative of SGLT2 inhibitor, inhibits kidney glucose resorption and promotes the urine excretion of glucose. However, there are few large studies with DAPA in combination with other hypoglycemic agents to treat type 2 diabetes. The results are, according to available data, the DAPA combined with the oral hypoglycemia can effectively reduce the levels of HbA1c and body weight. However, it doesn't increase the incidence of hypo, but can cause sometimes urinary tract infections and genital infections. So it's a very, very safe drug, except for the some amount of increase in the urinary tract infections. Dapagliflozin combined with the oral hypoglycemic agents could effectively reduce HbA1c and body quality without increasing the incidence of hypoglycemia. So one of the major concerns about the treatment with the OHs is to prevent the hypoglycemia. So it remains a safer drug to reduce the incidence of hypoglycemia. Similarly, weight gain, which is again a very problem with the many OHs, we have reduction in weight up to 4 to 5 kgs along with the combination and 3 kg alone. So weight loss and the increase in the control of the blood sugar, euglycemia, decrease in the hypoglycemic events, and with the easy accessibility, easy tolerability, and the now with the rate of the drugs getting in a sizably down, and it is a fairly affordable drug, you can use this drug as a first priority. So it is an adjunct therapy to insulin in patients with type 1 diabetes. There are few trials with the type 1 diabetes also. DAPA is the only currently available SGLT2 inhibitor indicated an adjunct therapy with the type 1 diabetes. The subgroup with the BMI more than 27 depict 2 trials with dapagliflozin evaluation type 1 patients showed a similar reduction in hyperglycemia and body weight with no significant increase in the ketoacidosis than the overall trial population. So this is a very, very fairly good trial which shows that we are always scared of increase in the ketoacidosis, which was not seen in this trial. In the CVD trials, so we know that SGLT2 does what? It does cardio protection. Cardio protection by what? Classical cardiovascular risk factors are decreased, such as blood pressure, weight, glucose, uric acid, and albuminuria. So these are the ways it affects the cardiovascular system. Hemodynamic effects increases the osmotic diuresis, improves the natriuresis, decreases the fluid overload, decreases the arterial stiffness, increases the endothelial functions. Endocrine effects increases the beta cell function, decreases the insulin resistance, increases the glucagon, decreases the sympathetic tone, increases the ACE-NG17. Myocardial infarcts increases the ketones, NHE1, inflammation is decreased, oxidative stress is decreased, and finally the myocardial stretch is decreased. The things, it is a win-win with the SGLT2s, whether it is the cardiovascular risk factors, hemodynamic, endocrine, myocardial effects. So we have centrally achieving the cardio protection with the SGLT2 inhibitors. SGLT2 are not only to reduce the high glucose dependent on the insulin, but also improve the blood pressure, body weight, lipid profile, ketones, and uric acid to present cardio protective effects. We have seen this in the previous slide also. You have decrease in the glucose, increase in the lipid utilization, decrease in the body weight, increase in the ketones, decrease in the uric acid, and decrease in the blood pressure. All these factors are going to give you a better control of the cardiovascular events in the diabetes. So what are the risks and benefits? So only in type 2 diabetes with cardiac abnormalities, there is a low risk of heart failure, frequency of hospitalization in the heart failure is decreased, cardiovascular mortality is decreased, non-fatal myocardial infarction is decreased, reduced body weight, decrease in the BMI, decrease in the systolic weight, reduction in all-cause mortality. However, you have slight risk of urinary tract infection, genital mycotic infection. However, the benefits outweigh these. There is reduced cardiac abnormalities, increased renal outcomes or improving the renal functions, decrease in on-cause mortality. So all the trials which we have done with GLT2 with different patients has shown that there is a benefit in all the conditions. Again, these are again metformin combination with the dapform, whether it's alone or with the combination with the metformin. We have different trials to evaluate the effects of dapa with SGLT2 inhibitors, dapa plus metformin, metformin alone in patients with the metabolic syndrome. Again, the results were dapa improves all components of metabolic syndrome in patients with metformin. Dapa in combined with metformin showed much better results of the than the DAPA or metformin alone. So combination with metformin, especially in the patients who are having a metabolic syndrome, initial initiation with the metformin as GLT2 is going to benefit those patients. So as DAPA has positive effects on multiple parameters of the metabolic, it may be the special effective ultimately reduce the cardiovascular events and mortality in such patients. So patients who are diagnosed initially with the metabolic syndrome or with the early onset of type 2 diabetes in the younger age group should be put on combination with metformin and SGLT2 to really have a better outcome in the long run. The present conclusion is no consensus on determining whether DAPA has a significant effect on occurrence of development of atherosclerosis in type 2 and patients. 12 randomized controlled HBMC, BMI, body weight, and the waist circumference. So all the components of the cardiometabolic syndrome are taken care of. So it should be first therapeutic option for progression of atherosclerosis in patients with type 2 diabetes. Again, diabetes and myocardial infarction. Again, meta-analysis of the different trials shows that SGLT2 treatment leads to reduction of 10 to 20% in the number of myocardial infarctions in the diabetic patients. So this is where we stand with the different trials. The class of drugs being evaluated in the different trials, where before DLP, SGLT2, basal insulin. So this is a drug which is showing you much better effects. So we are using this drug very, very more frequently. So DAPA and cardiovascular outcomes we have discussed in plenty. There is another trial which shows that DAPA and cardiovascular outcomes in type 2 diabetes. The results were safety endpoints, composite CV, death, myocardial infarction, stroke. The patients were around 8,500. Placebo was similarly. It is a trial declared which is a very, very important trial to evaluate the effect of DAPA on 10 milligram and placebo in the outcomes of the CV disease. So the results were DAPA, the SGLT2 with broadest implication to reduce the risk of hospitalization for the heart failure, 27% risk reduction in the overall population, 8% risk reduction. Reduction in the risk of hospitalization for heart failure in prescribed subgroups of primary secondary prevention patients. So you can see how much benefit you are going to drive out of using this drug, especially in the cardiovascular events. These drugs in the declaring that SGLT2 are the drug of choice in the persisting ACVD disease along with the diabetes. In type 2 diabetes with risk for atherosclerotic cardiovascular disease, treatment with similar trials. Again, dapa was associated with low risk of CV events, all-cause mortality compared with the PPP4 inhibitors in a real-world clinical setting and a broad DT2 population. You can all see that there is a definite improvement. The dapa is blue lines, so there is a definite margin in the two, and there is opening up of the gap. So it much better than DPP4 inhibitors whenever the cardiovascular events are concerned. DAPA from the real world experience. Of these drugs to more and more patients.
Sir, you are not audible. I think you are muted, sir. Sir, you are speaking on mute.
Hello.
Yes, sir. Now you are audible. Please share your screen, sir. I think I have it.
Hello.
Yes, sir.
Available now. I'm
Yes, sir.
audible now.
Yes, sir. Yes, sir. You are audible.
Okay. Hello. So, expert opinion about the pharmacoeconomic.
Sir, please share your screen, sir.
Hello.
Yes, sir. You are audible. Please share your screen.
My slides are not visible.
Your slides are not visible.
Right.
আজকে আমরা সবাই পড়েছি প্রোটিন শনিবার দিন আমাদের ক্যাজুয়াল থাকে তো আজকে আমরা সবাই পড়েছি মানে আমাদের পুরো এন্টার টিএমপি টিম আমরা সবাই তো সেটারও ফটো তোলা হয় ওটা ফেভার কি পাঠাবে এবার অজাত
Hello.
Yes, sir. You are audible. Your slides are
Visible
not
now?
visible. No, sir. Just share your screen, sir.
वही करता रहे तेरे को मैं एरिया मैनेजर बना देता हूँ अभी ट्रांसपोर्ट के एरिया मैनेजर आया ट्रांसपोर्ट तू भरता रहे you are buffoon.
Hello.
Now it is visible. You can
Is
continue.
it visible now?
Yes, sir.
Leave it here.
Okay. So we were talking about the. Sorry for the technical.
No worries.
The cost utility analysis of DAPA compared to the sulfonylurea for the type 2 diabetes as second line treatment with patients in the healthcare perspective. The objective was to this is an Indian trial which was to evaluate the long-term cost effectiveness of DAPA compared to the commonly used sulfonylureas as a second line drugs in the Indian patients with type 2. Compared to sulfas, DAPA was estimated to incur an additional cost of around 180 to 60-30 as compared to the 3.49 years 1.72 quality adjusted life gain, resulting in an increased cost effectiveness ratio of 52,000. So it was much effective as a drug. So we are gaining a lot out of the cost effectiveness by using this drug. Adit? Adit? Next slide. So, expert opinion about the pharmacological edge of low-cost DAPA type 2 diabetes. So, low-cost DAPA has been significant advantage in the primary prevention of heart failure with or without type 2 diabetes and in CKD patients in India. Low-cost DAPA reduces the overall cost of diabetes management in India. Low-cost DAPA has characteristic ideal SGLT2 such as metabolic benefits, cardioproduction, and nephroproduction. Low-cost DAPA has strong evidence of cardiorenal benefits compared to the REMO. So again, say effectiveness of safety of DAPA as real world trial, really. Data from the DAPA RWE Spanish multicentric study. So DAPA can be considered an excellent option for the comprehensive management of patients. The weight reduction, HbA1c reduction, and many of the patients receive reduction of HbA1c as weight combination. So DAPA can be considered an excellent option for the comprehensive management of diabetes. So summary, the glucose lowering efficacy of SGLT inhibitors in DAPA. So it's a class effect whether we are using CANA, whether we are IPRA or the DAPA. So almost similar, 0.91, 1.29. So almost 1% reduction in HbA1c with all this is a class effect of SGLT2s. Again, the dosage is that DAPA can be used in 5 to 10 milligrams. The bioavailability is 78% orally. Elimination is of course hepatic and renal. CANA 100 to 300 milligram bioavailability is 65, and again UGTI 80 and 2, 3, 4 B excretion, elimination, AMPA as well as DIPRA. These are the ways these drugs have the bioavailability up to 60 to 70%. So we know that DAPA does what really you want from any drug. It improves the symptoms, it improves the survival, it reduces the hospital admission, it reduces the cost effectiveness. So more than 80 trials ongoing beyond glycemic control in CVD, heart failure, in many other indications. So these are the many trials which are going on for DAPA in the preserved injection, DAPA in heart failure, DAPA in cardiovascular events in the acute heart failure, head-to-head comparison with AMPA and DAPA nighttime blood pressure changes, DAPA evaluation improve the life of patients, PR preservation, ejection fraction, DAPA in the diabetic patients with decompensated heart failure, efficacy and safety of DAPA in heart failure, DAPA in respiratory failure, DAPA in biomarkers in the patients with the heart failure, and many more studies are there in the pipeline. So what are we getting? The DAPA is going to bridge the gap. SGLT2 inhibitors recommended by reputed bodies such as ADA, ADASD, ACC, the management of type 2 diabetes, even preferred for reducing the hypoglycemia and weight gain. More than 350 completed trials available, and which has proved that the DAPA goes into the glycemic control as well as beyond it. Landmark CVOT trials like Declare TIMI 58 have shown survival benefits in diabetes and CVD. DAPA CKD Delight have shown improvement in the CKD with or without diabetes. So the future is bright, a much needed molecule bridging the gap of heart, kidney, and glucose. So in the future, you may really see this star shining more than the others, and maybe the first line of the drug in the management of young obese diabetics with the early onset of type 2 diabetes. Thank you. Thank you so much.
Thank you, Raj Kumar sir, for sharing your knowledge and which also enriched us and which also covered many aspects of dapagliflozin. We have received few questions. Sir, where will you place dapagliflozin in combination with vildagliptin in your clinical practice?
Dapa in combination with?
Vildagliptin.
Hello.
Yes, sir. Am I audible?
Hello.
Hello.
Yes. Yes.
Dapagliflozin with vildagliptin.
Combination?
Yes, sir. Combination. In your regular
Of
clinical
course.
practice.
I'm not the combination of dapa and vilda. You
Yes,
say?
sir. Yes, sir. Dapa.
Okay. We have gone through all the slides in the octet. We have seen that dapa has an effect on all the areas, but we saw in pancreas, it increases the insulin output. However, it increases the glucagon as well. However, once you have the increase in the glucagon, so in such cases, the combination with the DPP-4 inhibitors, which have a definite effect on reduction of glucagon, it has been combination with the beta-gliptin. If you give this drug, there is going to be benefit in reducing the glucagon, and you are going to get a better results and better control of HbA1c without changing the cardiometabolic symptoms or the effect on the cardiometabolic syndrome. You are completing the HbA1c reduction to the better extent because of the control of the glucagon, which was not there with the SGLT2 alone. And number two, you have seen in certain trials the urinary tract infection which was occurring with the SGLT2 alone. Once you are combining it with the DPP4, the incidence of genitourinary infections are going down. This is nobody knows why, but definitely there are trials which shows that.
Sir, what are the things do you remember while prescribing dapagliflozin in your clinical practice?
Hello?
Or their combinations? Hello, am I audible?
No.
Okay.
Please repeat.
What are the things do you remember while prescribing dapagliflozin or its combinations in your clinical practice?
I'm using both of them. We are using combination as well as the combination with the vildagliptin also, and we are using it alone also with the metformin or with the other OHs also. So it is in the younger age group with the cardiometabolic, we are using it as a first line therapy. While in older patients who have long time with using other OHs and not achieving the control, before putting on insulin, we are giving them that it is an insulin dependent control of diabetes because it has effect on the other the other factors, that is the renal absorption. So it is a insulin dependent role by SGLT2. Combining the SGLT2 with the other OHs or DPP4 inhibitor is going to give a better result.
Okay, sir. Final take home message for the audience as well as for us.
Once a drug which is very, very effective of as well, which is available nowadays, we should give the benefit to all the younger patients of diabetes who have course of the disease are going to have. So maybe in years to come, this drug may be used as guidelines by the ACC, as you may not use.
Hello. Sir, you are speaking on mute. You are speaking on mute, sir. You are not audible.
So reduce that. That could be
Hello. Hello.
Yes,
Yes,
now
sir,
you
you
are
are
audible.
audible.
I'm audible. Hello.
Yes, sir, you are audible. You can continue.
Okay. Hello.
Yes, sir, you are audible. You can continue.
So this drug should be used as a first priority. No, this is what my personal feeling is.
Okay. Sir, with this, we came the end of this meeting, sir. And finally, we thank from our entire MacLeod team for enriching our knowledge as well as audience knowledge and the dapa closing. Thank you, sir. Soon we will meet in future, sir. Can we wind up, sir? Thank you.
Hello.
Yes, sir, you are audible, sir.
Hello. Hello.
Yes, sir, you are audible. I think you from your side some network issues with it.
This is the instability of the internet here.
Okay, no issues, sir.
But any questions?
Questions from my side are completed, sir.
Okay, then we can close it, I think.
Yes, sir. Finally, we also thank one more Saringan, sir. Thanks for sharing your knowledge, enriching us, and also as well as audience. And soon we will meet in the future, sir, for more focused topics and more new topics. Prayag,
Yes, sir. Hello.
am I audible?
Yes, yes, you are audible, sir. Actually, the thing is, doctor's laptop voice is very low, so that's why he is not able to hear us properly.
Okay, am I audible to you? Like,
Yes, yes, you are
you can wind
properly
up
audible.
you can wind the meeting. Prayag.
Okay, thank you, sir. So from here now, I'm ending this meeting.
Okay, okay.
Thank you so much. Have a nice day.
Have a nice day too. Bye.
Bye.
सही बात है।